On the morning of July 25, 1972, a reporter named Jean Heller published a story for the Associated Press that ran in papers across the United States. The story was not long. It did not need to be. The facts, stated plainly, did the work. For 40 years, the United States Public Health Service had been conducting a study on the long-term effects of untreated syphilis in black men in Macon County, Alabama. The study had begun in 1932. It involved 399 men who had syphilis and 201 who did not. The men had not been told they had syphilis. They had been told they were being treated for something they called bad blood, a local term that covered a range of ailments. In exchange for their participation, they had received free medical exams, free meals on examination days, and burial insurance. They had not received treatment. This much might have been, if not defensible, at least understandable. In 1932, there was no cure for syphilis. The treatments that existed, arsenic compounds, bismuth preparations, were harsh, imprecise, and of limited effectiveness. A study observing the natural progression of untreated syphilis before a cure existed had at least the logic of curiosity, however troubling its ethical foundations. But then, in 1943, penicillin was shown to be effective against syphilis. In 1945, it became the treatment of choice. In 1947, it was standard, widely available, and inexpensive. In 1947, the men in the Tuskegee study were not given it. In 1948, they were not given it. In 1949, they were not given it. Not in 1950. Not in 1955. Not in 1960. Not in 1965. Not in 1970. In 1972, 25 years after a cure had become standard medical practice, 25 years after any physician treating a syphilis patient in the United States would have prescribed penicillin as a matter of course, the men in the Tuskegee study were still not being given it. The researchers had convinced local doctors not to treat them when men in the study were called up for the military draft in 1940. The researchers contacted draft boards to ensure those men were exempted from service, not out of concern for the men's welfare, but because military doctors would have treated them, and treatment would have disrupted the study. They blocked a cure. Not once. Incidentally, as an oversight, systematically, deliberately, over decades, across multiple administrations, through the participation of multiple institutions, they watched men go blind. They watched men go insane. The neurological effects of tertiary syphilis are among the most brutal of any disease process, involving the systematic destruction of the brain and spinal cord. They watched men die. They documented it. They published papers about it, 15 of them, in peer-reviewed journals, the most prominent of which was the Journal of the American Medical Association. The last paper was published in 1973, the year after the study was shut down. The study was not shut down because the researchers decided it had gone far enough. It was shut down because a 29-year-old whistleblower named Peter Buxton, who had been trying to stop it since 1966, finally got so frustrated with the bureaucracy that he gave his files to a journalist. And here is the thing that makes this story different from other stories about powerful institutions doing terrible things in secret. This was not a secret. The first published paper about the Tuskegee study appeared in 1936, 4 years after it began, in the Journal of the American Medical Association. Every 4 to 6 years thereafter, the researchers published updates, in 1964. They published a paper in Archives of Internal Medicine titled The Tuskegee Study of Untreated Syphilis, the 30th Year of Observation. The title was not coded. It was not euphemistic. It said exactly what the study was: an observation of untreated syphilis in its 30th year, in a peer-reviewed academic journal, accessible to any physician, any researcher, any medical student in the country. For 36 years, from 1936 to 1972, the American medical establishment had access to publications describing a government study in which black men with syphilis were being denied treatment in the name of science. In 36 years of published research, not one physician published a letter challenging the ethics of the study. Not one medical institution publicly objected. Not one government oversight body intervened. When the study was finally exposed, a researcher named John Heller, not the journalist Gene Heller, a different Heller, one of the study's former directors, told journalists there was no racial side to this. It just happened to be in a black community. I feel this was a perfectly straightforward study. Perfectly ethical, with controls. Perfectly ethical. The study's subjects, but 1972, included 28 men who had died directly from syphilis, more than 100 who had died from related complications, at least 40 wives who had been infected, and 19 children who had been born with congenital syphilis, a disease transmitted from mother to child during pregnancy that causes bone deformities, seizures, blindness, and death. 40 wives, 19 children, people who were never in the study, people who never agreed to anything, people who were harmed because the government was watching the men they loved while withholding the cure that would have protected them. Perfectly ethical. This episode is about what the Tuskegee study was, how it came to be, how it ran for 40 years without meaningful external challenge, who sustained it, who tried to stop it, and what it cost, not just in lives. Though the lives are not abstract numbers, they are specific men and women and children whose names exist in government records, but in the particular currency that institutional betrayal always extracts: trust. Because the full cost of the Tuskegee study is not measured in the 128 deaths that can be directly attributed to it. As terrible as those deaths were, the full cost is measured in every black American who, in the years and decades after 1972, chose not to see a doctor when they should have, chose not to participate in a clinical trial that might have helped them, chose not to trust the medical institution that was, in principle, there to help them because the institution that was supposed to help them had spent 40 years watching them die on purpose, writing papers about it, and calling it science. A 2016 study by economists Marcella Alsan and Marianne Wanamaker found that the disclosure of the Tuskegee study in 1972 was correlated, in the years that followed, with measurable increases in medical mistrust and mortality among older black men, and measurable decreases in both their use of outpatient and inpatient medical care. The researchers estimated that the Tuskegee disclosure was responsible for a reduction in life expectancy of approximately 4 years for black men over 45 in the areas most directly affected. That reduction, applied across the affected population, accounts for more deaths than the study itself directly caused. The study killed 128 people. The distrust the study created killed more. This is the specific mechanics of how institutional betrayal operates. It does not end when the institution stops doing the thing. It continues through the communities that were betrayed. For generations, the men and women who grew up hearing about Tuskegee from parents, grandparents, community members who had lived through it carried that knowledge with them into every interaction with the medical system. The knowledge was not irrational. It was not paranoia. It was an accurate assessment of documented historical fact. The government had done this. The medical establishment had permitted it. These were not conspiracy theories. They were court records. In 2021, as COVID-19 vaccines were rolling out, and public health officials were desperately trying to reach vaccine-hesitant communities, surveys found that Black Americans expressed lower initial vaccine confidence than white Americans, and that the single most commonly cited reason, in focus groups and interviews, was Tuskegee, not as a vague cultural memory, as a specific event, with specific facts, that a significant portion of the Black American community knew about and had incorporated into their assessment of how much the government could be trusted when it said a medical intervention was safe and for their benefit. The men of Tuskegee had been dead for decades. The study had been closed for 50 years, and it was still, in the middle of a pandemic, costing lives. That is the measure of what it means for an institution to manufacture a lie in the name of science. Not just the immediate dead, the long dead, the still being counted dead. This is the story of how it happened. To understand how the Tuskegee study happened, you need to understand what Macon County, Alabama looked like in 1932. Macon County was, by almost any economic measure, one of the poorest counties in the United States. Its economy was built almost entirely on cotton, sharecropping, and the specific system of debt and dependence that had replaced formal slavery in the post-Reconstruction South with a set of economic arrangements that produced very similar results. Black families who farmed in Macon County typically did not own the land they worked. They rented it, or more precisely, they worked it in exchange for a portion of the crop, minus the supplies. Their landlords had advanced them at interest rates that frequently consumed the entire value of the harvest. The credit system in operation across the Alabama Black Belt, the band of counties named for the rich, dark soil that made cotton farming viable, was, as a recent social trends report of the era noted with characteristic understatement, weak to begin with, and its abuses make it even more burdensome. In Macon County, in 1932, the Great Depression had been in progress for 3 years, and it had hit the sharecropping economy with particular violence. Cotton prices had collapsed, credit had dried up. Federal relief was administered through local officials whose relationship to the Black population of Macon County was, to put it diplomatically, not one of concern for their welfare. The county had almost no medical infrastructure accessible to its Black residents. There were no Black doctors in private practice in most of Macon County. The one significant medical institution available to Black residents was the John A. Andrew Memorial Hospital at the Tuskegee Institute, and access to it required the kind of transportation that most sharecropping families did not have. This meant that the majority of Black men in Macon County had never, in any meaningful sense, received professional medical care. They had been born at home, treated at home, and died at home. When they got sick, they treated themselves with the resources available to them, which were not nothing. The folk medical knowledge of rural Black Alabama was extensive, practical, and in many cases effective, but it was knowledge without access to the interventions that institutional medicine could provide. The men of Macon County were not ignorant about health. They were poor. There is a difference, and it matters enormously to understanding what happened next. Syphilis was widespread in Macon County in 1932. This was not specific to Macon County. Syphilis was widespread throughout the rural South, and the prevalence rates in Black communities across the region had been alarming public health officials for years. The reasons for the disparity were not, as researchers of the era frequently and lazily suggested, genetic or cultural. They were structural. Syphilis spreads through sexual contact, and its spread is facilitated by poverty. by the absence of medical care, by the disruption of family structures caused by economic precarity, and by the specific legacy of sexual violence and coercion that slavery had imposed on black communities, and that its aftermath had perpetuated in different forms. The men and women of Macon County had high rates of syphilis because they were poor, medically underserved, and living in a social and economic environment that the history of the American South had specifically designed to keep them that way. The disease was a symptom. The poverty was the underlying condition. The United States Public Health Service had been aware of the syphilis problem in the rural South for years. In 1929, the Julius Rosenwald Fund, a philanthropic organization established by the founder of Sears, Roebuck and Company, and one of the major private funders of black education and health in the South, sponsored a syphilis control study across 6 southern states. The USPHS collaborated in this study, which was designed not merely to measure the prevalence of syphilis, but to establish clinics in affected communities and actually treat the disease. This study, the precursor to everything that followed, found high rates of syphilis in the communities it examined, and began, in a limited way, to provide treatment among the 6 states, and the researchers chose 1 county from each for their pilot program, selecting sites near lumber or tobacco manufacturing, with high rates of syphilis and, crucially, no history of civil unrest that might complicate the work. Macon County, Alabama, with a population that was 82% black, a syphilis prevalence that surveys suggested was extremely high, and a black educational institution, the Tuskegee Institute, that could provide logistical and community support, was selected as the Alabama site. The Rosenwald Fund study operated for several years, testing and treating residents of Macon County for syphilis. The treatments available at the time were not penicillin. Penicillin had not been developed yet. They were arsenic-based compounds, arsphenamine, sold under the trade name Salvarsan, and its successor, neoarsphenamine. These were not comfortable treatments. They involved a series of injections spread over many months. The arsenic could cause serious side effects, but they were real treatments. They reduced the severity of the disease, limited its most catastrophic late-stage effects, and in some cases appeared to halt its progression. They were what medicine had to offer against syphilis in 1930. And the Rosenwald Fund was offering them. Then the Depression deepened. The Rosenwald Fund, whose assets were tied to the performance of Sears stock, found itself financially strained. The treatment program in Macon County and in the other counties was determined to be too expensive to continue. Funding was withdrawn. This left Taliaferro Clark, the chief of the USPHS Venereal Disease Division in Washington, D.C., with an interesting problem. He had a population in Macon County that had been surveyed, tested, and partially treated for syphilis, and he no longer had the funding to continue the treatment phase. What he also had, however, was an unusual research opportunity, a large population of black men in whom syphilis had been documented and measured. In a county that had the institutional infrastructure of the Tuskegee Institute to support ongoing work, at a moment when the scientific literature on syphilis in black men was, by his assessment, incomplete. The scientific question Clark wanted to answer was, in the idiom of the era, respectable. He wanted to know whether syphilis affected black men differently than it affected white men. The existing literature on untreated syphilis, the Oslo study, a Norwegian study of white Europeans with untreated syphilis conducted in the early 20th century, showed a specific pattern of disease progression. Clark's hypothesis, drawing on what he described as clinical observation and on the broader framework of racial medicine that characterized American medical thinking of the era, was that syphilis might manifest differently in African Americans, perhaps with a greater tendency toward cardiovascular rather than neurological effects. This was a clinical question. It was also, as we will see, a question that was thoroughly entangled with the racial assumptions of its era, and whose specific framing studying whether the disease was different in black men could only make scientific sense if you began with the premise that black men were biologically different in ways worth studying specifically. In 1932, Clark proposed a study to observe the natural history of untreated syphilis in black men in Macon County. The study's original design was modest in scope, 6 to 8 months of observation, following men with already established late-stage syphilis to document the disease's progression. There would, in the original plan, be a treatment phase after the observation period, which would have made the study, however ethically questionable its observation phase, at least partially defensible from a public health standpoint. The men would be watched, and then they would be treated. Clark wrote to the Surgeon General of the United States, Hugh Cumming, seeking authorization. Cumming's response to Clark's proposal has been preserved in the historical record, and it is worth quoting because it tells you, in a single sentence, everything about how the scientific establishment viewed the opportunity it was being offered. Cumming wrote that the proposed study offers an unparalleled opportunity for carrying on this piece of scientific research, which probably cannot be duplicated anywhere else in the world. Unparalleled cannot be duplicated anywhere else in the world? He was right. Of course, the conditions that made Macon County ideal for this study, a large population of poor black men with untreated syphilis, accessible through an established institutional relationship, in a county with no functioning medical infrastructure that might inconveniently treat them, could not easily be replicated in, say, Chicago, or Boston, or anywhere that the men in question had meaningful access to care, or political representation, or the kind of social visibility that makes it uncomfortable to use them as research subjects without their knowledge. The unparalleled opportunity was translated from the language of scientific enthusiasm into plain English. The opportunity to study what happened to black men when they got no medical care. This was unparalleled not because of any unique biological characteristic of the study population, but because the structural conditions of Southern poverty and racial inequality had produced a situation in which a large group of men had never received and could not easily access treatment for a serious disease. The scientific opportunity was a poverty opportunity. The rarity that made it scientifically interesting was the rarity of human beings sufficiently poor, sufficiently black, and sufficiently far from the institutions of power that the people running the study did not feel required to treat them. Cumming presumably did not intend any irony. Almost certainly, he did not. The study was approved. Clark moved quickly. He enlisted the cooperation of the Tuskegee Institute, which agreed to provide laboratory facilities and the crucial endorsement of a black institution, an endorsement that would prove essential in recruiting participants and maintaining the study's legitimacy in the community. The Institute's hospital director, Dr. Eugene Dibble, agreed to participate. The Institute's principal, Robert Morton, gave his blessing. These were not naive people. They were the leadership of one of the most distinguished black educational institutions in America, operating in a social and political environment in which cooperation with federal health programs was seen as a form of advocacy for black health, a way of demonstrating that the government had an obligation to care about the medical needs of black Americans. Their involvement was, in their own understanding, a form of protection for the community, a way of ensuring that whatever happened, a black institution was at the table. The study was organized in the fall of 1932. Raymond Fondalier, a USPHS officer, who would become the study's primary operational director in its early years, was dispatched to Macon County to set up the program. Word was spread through the community that government doctors had returned the same doctors who had done the testing during the Rosenwald Fund program, and that a new health program was beginning. The messaging, from the start, was carefully designed to obscure what the study actually was. The men who were recruited were told they were being treated for bad blood. This was not a meaningless euphemism. Bad blood was a real term, in common use in rural Black Alabama, that covered a range of ailments: syphilis, anemia, fatigue, general poor health. The doctors used the term deliberately, because it connected the study to the health concerns the men actually had without disclosing the specific diagnosis that was being observed. The men were not told they had syphilis. They were not told that the study was observational rather than therapeutic. They were not given the kind of information about what was happening to their bodies that would have been necessary for genuine informed consent indeed. The concept of informed consent as a legal and ethical requirement in medical research did not become standard American medical practice until the 1970s. And even by the looser standards of 1932, the deception practiced at Tuskegee was extensive. In exchange for their participation, the men received free medical examinations, free meals on the days of their examinations, transportation to the examination site. And this detail is important and worth dwelling on: burial insurance. The burial insurance was, in the context of rural Black Alabama in 1932, a significant benefit. Burial was expensive. Dying without burial insurance meant that your family bore the cost of your funeral, often straining already stretched finances. The offer of burial insurance was, for the men of Macon County, a concrete, practical benefit more immediately meaningful, in many cases, than the abstract promise of medical care. It was also, from the perspective of the researchers, a mechanism for ensuring that the men's families would permit autopsies, the examination of the men's bodies after death being one of the primary scientific objectives of the study. The researchers needed autopsies. The study's core purpose was to document the pathological effects of untreated syphilis, the damage to organs, the cardiovascular and neurological changes, the specific ways in which the disease destroyed the body over time. This documentation required post-mortem examination by offering burial insurance in exchange for participation, and conditioning the benefit on family cooperation with autopsy. The researchers created a financial incentive for families to allow examination of the bodies of men they loved, whether the families understood that this was part of the bargain and whether they understood, if they did, and that the men had died of a disease the government had chosen not to treat, is not documented in the records in a way that allows certainty. What is documented is that autopsies were performed throughout the study, and that the researchers went to considerable effort to ensure they happened. The initial recruitment enrolled 399 men with late-latent syphilis and 201 men without the disease, the latter serving as a control group. The men with syphilis had already established infections. They had not been infected by the study. This is a fact that requires emphasis, because a persistent myth holds that the Tuskegee study involved deliberately infecting healthy men with syphilis. It did not. The men were recruited because they already had the disease. The crime was not infection. The crime was observation, watching a disease that medicine eventually learned to treat, and actively preventing the treatment, in the name of documenting the disease's natural course. The distinction matters, but it does not make the study less of a crime. If anything, the specific nature of what was done recruiting men who already suffered from a disease, building a relationship of trust with them over years and decades, and then withholding a cure that would have saved their lives and the lives of their wives and children, has a quality of deliberate betrayal that differs from infection in its texture without differing from it in its fundamental character. The men trusted the government doctors. The government doctors exploited that trust. They did it for 40 years. From the beginning, the study operated under a fundamental deception that it never abandoned. The men were given some medical attention, they were examined. Their blood was drawn. Their symptoms were documented. They were given aspirin and iron supplements and vitamin tonics, placebos. In the technical sense, though the researchers understood them as such, even if the men did not, the medical attention was real enough and sufficiently different from what most of these men had ever received, that it functioned as a believable simulation of treatment. Nurse Eunice Rivers, whom we will discuss at length in Chapter 3, described her role as including not just clinical duties but the cultivation of ongoing relationships with the men, listening to their concerns, helping their families with non-medical needs, maintaining the connections that kept men in the study year after year. The men knew Nurse Rivers. They trusted her. They called her Miss Rivers. They called the researchers the government doctor. They believed the government doctor was helping them. Meanwhile, in Washington, the study's original director, Taliaferro Clark, was leaving the program. Clark had conceived the study as a short-term observational exercise. He expected it to run 6 months to a year and then either conclude or transition to a treatment phase. What actually happened was that Raymond Vonderlehr, who was doing the field work and who had developed, by all accounts, a genuine scientific investment in the study's potential, decided that the most scientifically valuable course was to continue it. Continue not for 6 months. Continue indefinitely. Continue. Specifically, until all the subjects died and could be autopsied. Vonderlehr made this decision in consultation with his supervisors and with the institutional support of the USPHS leadership. It was not a unilateral act by a rogue researcher. It was an institutional decision made by an organization with legitimate federal authority. In the name of science, in 1933, Vonderlehr wrote to Clark, now departing the study, to explain his thinking. He argued that the study of untreated syphilis in black men was too scientifically valuable to cut short at the observation phase. He wanted to follow the men until death. He believed the scientific payoff of doing so, the documentation of the full disease course, the post-mortem pathological findings, the comparison with the Norwegian data on white men justified the continuation. Clark's response was characteristically ambivalent. He expressed concern. He suggested, in some correspondence, that the men ought eventually to be treated. He was, by the record, I'm aware that what was happening was ethically complicated. He left the program anyway. He retired in 1933 and was replaced by administrators who had fewer reservations about where the study was going. Vonderlehr became the director, and under his direction, the study that had been designed as a 6 to 8 month observation became something else, a 40-year project to watch 399 men die. The scientific justification for the study as it was actually conducted, not the polite version in the journal papers, but the functional rationale that explained why no one stopped it, rested on 2 premises that are worth examining directly. The first premise was that the scientific information being gathered was genuinely valuable. This premise was not entirely false. The study did generate data. The data did contribute to the understanding of late-stage syphilis. The 1936 paper in JAMA, the first major publication from the study, documented that men with syphilis had a mortality rate 17% higher than the control group in the same period, and identified specific patterns of cardiovascular and neurological damage. This was real information. It was also information that could have been gathered by treating the men for syphilis and documenting the effects before treatment. or by reviewing existing autopsy records, or by studying populations who had not received treatment because treatment was unavailable rather than because researchers were actively preventing it. The specific knowledge that required watching identifiable men die of a treatable disease and preventing them from receiving treatment was not as irreplaceable as the study's defenders sometimes claimed. It was, in the specific form the study took, the kind of data you could only get by doing something that you could not justify doing. The second premise was more insidious, that the men would not have sought or received treatment anyway. This argument, encountered repeatedly in the defenses offered by study participants over the years, holds that the men of Macon County were so poor, so medically underserved, so far from any functioning medical infrastructure, that the study was not really withholding treatment from them. It was merely observing a natural condition. They would have gone untreated regardless. This argument fails on the facts. The researchers did not merely observe a natural condition. They actively intervened to prevent treatment on multiple occasions. When local doctors in Macon County considered treating the study participants, the USPHS contacted them and asked them not to. When the military draft created a mechanism that would have resulted in many men receiving treatment because the military screened inductees for syphilis and treated those who tested positive, the USPHS contacted draft boards and arranged for the men to be exempted from induction. In 1943, as penicillin was becoming available and the standard of care for syphilis was shifting, the USPHS made explicit decisions not to offer it to the study participants. These were not passive observations of a pre-existing condition. They were active, documented, deliberate interventions to prevent the men from receiving care that the medical establishment now understood was available and effective. The 1936 decision to extend the study until death, the moment at which the 6 to 8 month study became a 40-year one, was also the moment at which the study's moral character was definitively fixed. In 1932, before penicillin, there was a defensible argument then, but real, that observing untreated syphilis served a scientific purpose that no alternative study design could achieve. But 1936, the researchers had already found significant evidence of disease progression and excess mortality. They had material for publication. They could, at that point, have transitioned the study to a treatment phase and generated equally valuable data on the effectiveness of available treatments. They did not. They decided to watch the men die. And then, in 1947, when penicillin arrived as a genuine, effective, inexpensive cure, not a palliative, not a stopgap, but a cure, the moral calculus became unambiguous. There is no scientific argument, however carefully constructed, that justifies watching human beings die of a curable disease in order to document what death from that disease looks like. There is no data set valuable enough to be purchased at that price. The researchers understood this. Their private correspondence, reviewed by historians, shows that they were aware of the ethical dimensions of what they were doing, aware that the study had moved far outside any defensible scientific boundary, and committed to continuing it anyway. They were committed because they had started something, because there were papers to write, because the data was accumulating, because stopping the study would mean accounting for why it had been run the way it had been run. Because, and this is the most discomforting explanation, the one that connects Tuskegee to every other story in this series, the institution had decided that the study was science. And once an institution decides something is science, the mechanisms of institutional inertia are very hard to reverse. The study had been approved. It had been funded. It had been published in journals. It had been reviewed by committees. It had the endorsement of the Tuskegee Institute, the cooperation of local government. the ongoing support of the USPHS, and eventually, the Centers for Disease Control and Prevention. It had been running for so long that stopping it would require someone to explain to all of these institutions, and to the scientific community, and to the public, and to the 399 men who had been told for decades that they were receiving care why it had run at all. No one wanted to make that explanation, and so it ran in 1969. With the study in its 37th year, the CDC convened a panel to assess whether it should continue. The panel included representatives from the CDC, from local chapters of the National Medical Association, the organization representing Black physicians, and from the American Medical Association. The panel reviewed the study. It considered the question of whether it should be terminated. It concluded that the study should continue. Both the American Medical Association and the National Medical Association, the white organization and the black one, endorsed the continuation of a study that was, at that point, actively preventing treatment of syphilis in black men who could be cured with a $20 prescription. The CDC, whose institutional ancestors had established the study and maintained it for 37 years, agreed. This decision was made in 1969. Neil Armstrong had walked on the moon. The Voting Rights Act had been law for 4 years. The Nuremberg Code, which established that informed consent was a prerequisite for any medical research on human subjects, had been written 22 years earlier, specifically to prevent the repetition of the Nazi medical experiments that had shocked the world. The men of Tuskegee had been alive for those 22 years. They had been denied treatment for those 22 years, through the period of Nuremberg, through the Korean War, through the Civil Rights Movement, through the passage of Medicare and Medicaid, through the era in which the federal government had officially, legally, repeatedly committed itself to the principle that black Americans had equal rights under American law. The Tuskegee study ran through all of it. It ran because institutions, once they have decided something is science, are extraordinarily good at finding reasons to continue calling it science. It ran because the men it was running on were poor, black, and from Alabama, and in the United States of America, in the 1930s and 1940s and 1950s and 1960s. Being poor and black and from Alabama meant that the people who designed the study, who funded it, who reviewed it, and who endorsed its continuation had never seriously been required to ask themselves the question that the study's existence demanded: would we do this to people who looked like us? The answer, given the study's 40-year history, is clear. They would not have. Before we can understand what was done to the men of the Tuskegee study, we need to understand who they were. They were sharecroppers, mostly farmers who worked land they did not own, in a county whose economic structure had been designed to keep them poor. Some had small plots of their own land, a significant aspiration in black Alabama of the 1930s, and an achievement that the study's records note, with a kind of detached sociological interest that tells you something about the relationship between the researchers and the researched. Most did not. Most worked for white landowners under arrangements that, after the landlord took his share, after the credit advances were deducted, I left very little for the family that had done the planting and the harvesting and the hauling. The men were, on average, in their 40s when the study began. Some were older. They had lived, most of them, their entire lives in Macon County or in the region around it, in the Black Belt counties of central Alabama, where the soil was rich and the economic arrangements were old and the racial hierarchy was enforced with the casual, systematic thoroughness of a region that had been doing it since before the Civil War. They had, most of them, attended school for only a few years before work demands pulled them out. They could read, many of them, though not all. They had survived the Depression with the particular resilience of people who had not had much to lose in the first place, and had therefore not lost as much as those for whom the collapse of 1929 represented a fall from something. They had, almost certainly, never in their lives had access to a doctor who would sit with them, ask about their symptoms, draw their blood, examine their bodies with professional attention and clinical care. The John A. Andrew Memorial Hospital at Tuskegee Institute existed and was accessible to some residents of the county, but it required transportation, and transportation required money. And money was the thing the sharecropping system was specifically designed to ensure remained scarce. What the men had, medically, was each other, the knowledge of neighbors and family members, the advice of church elders, the folk remedies that have been carried through generations, the specific medical understanding that comes from living close to the land and paying careful attention to the body. When the government doctors arrived, they arrived with something these men had never had: access. The promise of real examination, real attention. Realcare. The blood tests and the physical exams and the aspirin and the vitamins were not nothing for men who had never had a professional medical examination. The examination itself was a form of care, or close enough to it. In the specific conditions of Macon County in 1932, that the distinction between genuine treatment and placebo was not easily visible. This is why the deception worked. Not because the men were stupid, they were not, but because the simulation of medical care was sufficiently convincing, given the baseline of what they had access to, and that distinguishing between genuine treatment and performance required exactly the kind of outside information they were specifically being denied. Know what syphilis actually does to a body. This matters. This matters specifically and in detail, because the clinical reality of untreated syphilis is one of the things that tends to be abstracted away in discussions of the Tuskegee study, reduced to numbers of dead and statistics of damage, when what it actually was is a specific, documented, extended process of suffering that was observable to any researcher with eyes and a conscience, and was observed, documented, and published, and continued anyway. Syphilis is caused by the bacterium Treponema pallidum. It is a spiral-shaped organism that burrows into tissue, evades immune responses with unusual effectiveness, and spreads throughout the body via the bloodstream. It progresses in stages, and the progression is slow enough, and the late stages delayed enough, that syphilis has been called, for centuries, the great imitator, because its symptoms resemble those of dozens of other conditions, and because it can lie dormant for years before its most devastating effects become visible. Primary syphilis, a painless sore, called a chancre. At the site of infection, it heals on its own, without treatment, typically within 3 to 6 weeks. Most people who notice it assume it was nothing. Many people never notice it at all. Secondary syphilis, a rash, often covering the palms and soles of the feet. This characteristic distribution is one of the few clinically distinctive features of the disease. Flu-like symptoms, sores in the mouth, hair loss. The rash resolves on its own. The person feels better. Many people, at this point, believe whatever they had is over. It is not over. Latent syphilis. The bacterium retreats. No visible symptoms. The person feels, functionally, well. This phase can last years, often a decade or more. And during this period, the bacteria are slowly, quietly, methodically destroying tissue, spreading into the cardiovascular system, infecting the brain and spinal cord, attacking the walls of the aorta, the main artery from the heart, from the inside. building the infrastructure of a catastrophe that will not become visible for another decade, or 2 decades, or 3. The men of the Tuskegee study were recruited in the late latent phase after the obvious early symptoms had resolved. In the quiet years before the disease delivered its final damage. This is why the study's early observation phase produced relatively little immediately visible disease. The men looked to casual examination. Largely fine. They were not fine. The damage was accruing. But the researchers needed to wait for it to manifest. Tertiary syphilis, when it arrives, is not subtle. In the cardiovascular system, the bacteria attack the walls of the aorta, causing a condition called aortitis, inflammation of the aortic wall that weakens it, causing it to bulge outward and, in severe cases, a rupture, aortic aneurysm, the aortic valve, which controls blood flow from the heart, can be damaged, causing aortic regurgitation, the heart pumping blood forward only to have it flow backward into the ventricle, forcing the heart to work harder and harder to compensate until it eventually fails. Angina, heart failure, death. The 1936 Tuskegee paper documented higher rates of cardiovascular mortality in the syphilitic group, which was the specific finding researchers had been looking for. Confirmation that the disease was tracking differently in this population, that it was tracking through their hearts. While they watched. In the nervous system neurosyphilis, the bacteria attack the brain and spinal cord with a thoroughness that belongs among the most brutal disease processes in medicine. Tabes dorsalis. Destruction of the posterior columns of the spinal cord, causing a progressive inability to sense the position of the limbs, resulting in a characteristic ataxic gait, a stumbling, high-stepping walk, and eventually the loss of coordination severe enough to prevent standing without assistance, shooting pains in the legs, loss of bladder and bowel control, the Argyll-Robertson pupil, a neurological sign in which the pupil of the eye no longer reacts to light but still accommodates to near objects, a sign so specific to neurosyphilis that its presence in a patient is still, in modern medicine, considered nearly diagnostic. General paresis, a progressive form of dementia caused by direct bacterial invasion of brain tissue. Personality changes, memory loss, delusions, the inability to perform basic calculations, the dissolution, over years, of the person who inhabited the body, blindness, deafness, the destruction of the bones of the skull from within, a condition called gummatous syphilis, in which the bacteria form masses of inflamed tissue that invade and destroy bone and soft tissue. The nose collapsing, a historic sign of tertiary syphilis known for centuries, documented in medical texts going back to the Renaissance. The physical marker that told communities, before laboratory tests existed, that a person had been consumed by the disease. These things happened to the men of the Tuskegee study. They happened in the presence of researchers who documented them, photographed them in some cases, wrote about them in peer-reviewed papers, and continued not to provide treatment. And the specific cruelty of the study's timeline is this. Most of these outcomes, the aortic aneurysms, the cardiac failure, the progressive neurological deterioration, were preventable. Not in 1932, when penicillin did not exist, but in 1947. When it did, penicillin kills Treponema pallidum with remarkable efficiency. A course of penicillin injections administered to a person with latent syphilis will, in the vast majority of cases, eliminate the bacteria from the body and prevent the development of tertiary disease. It will not reverse damage that has already occurred once the aortic wall has been weakened, once the spinal cord has been damaged. Some of the injury is permanent, but it stops the progression. It prevents the worst of what comes next. It is measured against the alternative. One of the more dramatic interventions in the history of medicine. An inexpensive antibiotic that transforms a sentence of progressive destruction into a manageable, curable condition. The researchers knew this. They knew it in 1945. They knew it in 1947. They knew it in 1950. When some of the methods in the study were beginning to show the cardiovascular and neurological effects that penicillin could have prevented, they knew it in 1955 and 1960 and 1965. They watched anyway. They watched, and then they wrote it up, and then they published it. And the world's scientific establishment read the papers and said nothing that amounted to stopping it. Let us be precise about the mechanisms by which the men were prevented from receiving treatment. Because there were several, and they were not passive. The researchers did not merely decline to prescribe penicillin themselves. They actively worked to prevent the men from receiving it from any source. In 1936, von der Leyen wrote to local physicians throughout Macon County and asked them to cooperate with the study by refraining from treating any patients who had been enrolled. He gave the local doctors a list of the men's names. He asked that if any of these men sought treatment for syphilis, or for any serious illness that might involve syphilis-related complications, the doctors notified the study rather than treating them. The doctors, for the most part, complied. This was not an aberration in the local medical culture. It was consistent with the role that the USPHS had established for itself as an authority, whose cooperation was worth maintaining. This letter addressed to physicians who had taken an oath to do no harm, asking them to help ensure that identifiable patients with a treatable disease did not receive treatment is one of the more chilling documents in the study's archive. It is also an unusually clean illustration of how institutional science can conscript professional ethics into its service. The doctors were being asked not to do something harmful. Exactly. They were being asked to defer to a study that their own professional obligations should have made them challenge. They deferred. Then came the draft. In 1940 and 1941, as the United States was moving toward military mobilization in advance of formal entry into World War II, draft boards across the country began calling up men for military service. The draft screening process included medical examination, and the military screened for syphilis as a matter of course. Men who tested positive were referred for treatment. The military had a strong operational interest in treating syphilis among servicemen. And penicillin, while not yet the standard treatment in 1941 and 1942, was arriving as the intervention of choice by 1943 and 1944. Many of the men in the Tuskegee study were called up. The draft letters arrived at their homes. For a brief moment, the apparatus of another arm of the federal government, the military, was in a position to do what the USPHS was deliberately not doing: treat them. Von der Leyen moved quickly. He contacted the local draft boards in Macon County and requested that the study participants be exempted from induction. He argued, with the authority of the federal health establishment behind him, that the men were involved in an important government health study and could not be spared. The draft boards cooperated. The men received letters informing them they were not to report for induction, and the draft board letters, in some cases, said explicitly that this was related to their involvement in the government study. The men were, in some cases, not unhappy to avoid military service. That is not the point. The point is that the researchers intervened in the operation of a separate arm of the federal government to prevent the men from being seen by military doctors who would have treated them. The point is that in 1941 and 1942 and 1943, as the United States was fighting a war partly in the name of human dignity and freedom, the United States Public Health Service was calling in favors with Alabama draft boards to ensure that 399 black men with syphilis did not get the treatment that would have cured them. The exemption letters went out. The men stayed home. The study continued. By 1947, penicillin was so established as the treatment for syphilis that any physician treating a syphilis patient who did not prescribe it would have been practicing medicine below the standard of care. The USPHS itself, the same organization running the Tuskegee study, was actively promoting penicillin as the treatment of choice for syphilis in its public health campaigns across the country. The organization was running 2 programs simultaneously. One telling the American public to treat syphilis with penicillin, and one specifically preventing 399 men in Alabama from receiving penicillin. The people running these 2 programs were in the same agency. In some cases, they were the same people. In 1950, John Heller, the study's director from 1943 to 1948, the man who would later tell journalists that the study was perfectly ethical, oversaw explicit decisions to exclude study participants from the penicillin programs being run in Macon County by local health departments. The local health department was running syphilis treatment clinics in Macon County. These clinics were treating syphilis with penicillin. The Tuskegee study's participants were being specifically identified and excluded from those clinics. So, the public health infrastructure of the United States was treating syphilis with penicillin in Macon County. In the same county, in some cases for the same men, and the USPHS study was tracking those men, identifying them, and making sure they did not get into the clinics. This is the specific operational reality of what the study was doing after 1947. Not passively observing untreated syphilis, actively maintaining it, intervening in the local health system to ensure that penicillin, which was being offered by other government programs to other people in the same county, did not reach these specific 399 men. The scientific justification for this, at that point, was essentially bankrupt. The researchers knew what penicillin did. They had published papers. They had data. The hypothesis that syphilis progressed differently in black men than in white men. The rationale that had animated Clark's original proposal had been examined and re-examined in enough papers that whatever incremental scientific value the study might still generate was far outweighed by the ongoing harm of denying treatment to men who were dying of a curable disease. But the study had momentum. It had been running for 15 years. It had institutional support. It had data sets. It had ongoing autopsy agreements. It had Nurse Rivers, who drove the men to their appointments and handed them their aspirin and built the relationships that kept them enrolled year after year, and whose career and professional standing were now, after 15 years, bound up with the study in ways that made her difficult to separate from it. It had researchers who had built their professional reputations on its publications and who had a significant career interest in its continuation. It had the endorsement of the CDC, which had absorbed the USPHS's Venereal Disease Division in 1957, and with it the study's ongoing management and the implicit endorsement of a medical establishment that read the papers every 4 to 6 years and found no reason to object. The papers kept coming. The 1,955 paper documented cardiovascular findings. The 1,960 paper documented neurological findings. In 1964, 20 years after penicillin had become the standard treatment for syphilis, the Archives of Internal Medicine published the Tuskegee Study of Untreated Syphilis, the 30th year of observation. The title did not hide what the study was. It was in the title, Untreated Syphilis, 30th year, in a peer-reviewed journal, accessible to any physician in the country. No physician, in the 36 years of publication that preceded the study's exposure, published a letter in any medical journal challenging its ethics. Not one. This is, in the full history of the Tuskegee study, one of the most damning facts not about the individuals running the study, whose moral failures are documented and specific, but about the American medical establishment as a whole. The data was public. The title of the study was explicit. The fact that men with syphilis were being observed without treatment was not hidden. It was in the title. It was in the methods sections. It was in the annual reports that the USPHS filed as a matter of bureaucratic routine. The medical establishment read these papers. It reviewed them. It cited them. It incorporated their data into the understanding of syphilis pathology. And it did not ask, in any formal or consequential way, whether the way in which the data was being gathered was consistent with the profession's ethical obligations to the people it was supposed to serve. The answer to why it didn't ask is not comfortable. It involves the specific way in which medicine in mid-20th century America thought about its obligations to black patients. It involves the specific way in which poverty and race affected whose suffering was legible as suffering, and whose death was experienced as a problem, requiring action. It involves the fact that the people publishing the papers were government doctors at respectable institutions, and that in the culture of mid-century academic medicine, the production of peer-reviewed research by accredited institutions was very close to the definition of science. And science, by the specific circular logic that this series examines in every episode, was not required to justify itself to the people it was studying. The men kept coming to their appointments. They had been coming since 1932. Some of them had been coming for 20 years by the time penicillin was widely available. They came because Nurse Rivers drove them. They came because there were free meals on examination day. And free meals were not nothing in Macon County, Alabama in the 1940s and 1950s. They came because the government had given them burial insurance. And the insurance was real, and the family needed it. They came because, for men who had never had consistent access to medical attention, the annual examination, even an examination that gave them aspirin instead of treatment, represented a form of acknowledgement that their bodies mattered, that their health had value, that someone in the apparatus of the American state thought it was worth spending an afternoon with them. They called the researchers the government doctor, and they trusted the government doctor. They had been trusting the government doctor for years, for decades. They had told their neighbors about the program. They had, in some cases, convinced friends and relatives to enroll. They had built the relationship from their side that the researchers depended on from theirs. The researchers knew this. The trust of the men was not incidental to the study's design, it was the study's operational foundation. Without it, men would not have showed up year after year for examinations that did not treat them. Without it, families would not have consented to autopsies. Without it, the study could not have been run for 40 years on the same population, and the trust was built on a lie, not a small lie, not a technical omission, or a research protocol whose ethical dimension was ambiguous, a specific, operational, maintained lie that the men were receiving care, that the examinations were treatment, that the aspirin and the vitamins were medicine, that the government doctors cared about what happened to them. The government doctors did not care about what happened to them. The government doctors cared about what happened to the data. There is a specific document in the historical record, a letter from von der Leer, written in the early years of the study, that makes this clear, with a directness that even its bureaucratic language cannot fully obscure. Von der Leer, writing to a colleague, discussed the study's subjects in terms that capture exactly the relationship the researchers had with the men they were studying. He referred to the men as subjects. He discussed their medical status in terms of their value to the data set. He expressed concern, at one point, that some of the men might leave the study area, not concern for what would happen to those men's health if they left, but concern about the attrition in the study population. These are the specific cognitive moves of institutional science that has stopped seeing the people it studies as people. The men were enrolled in a study. The study was science. Science required subjects. The subjects were the men. The men's lives had value to the extent that they contributed to the study's findings. Their suffering, in this framework, was not a problem requiring intervention. It was data requiring documentation. This is not a feature specific to the Tuskegee researchers. It is a feature of research cultures that lack the ethical infrastructure to enforce the principle that human beings are not reducible to their data. Tuskegee happened partly because the researchers were capable of extraordinary moral compartmentalization, and partly because no external mechanism existed. In 1932, or in 1947, or in 1960, to force them to stop. The men who died, the 28 who died directly of syphilis, the more than 100 who died of complications were not statistics when they were alive. They were men with names. Charlie Wesley Pollard, Herman Shaw, Carter Howard, Fred Simmons. These men's names are in the government records. They are on the list of the 399. Some of them live long enough to hear, in 1972, that they had been lied to. Some of them were there, in 1997, when the President of the United States stood in the White House and said he was sorry. Some of them died before either of those things happened. Their bodies autopsied by the researchers who had chosen not to treat them. Their deaths documented in papers published in journals that the medical establishment read and found untroubling. The men who died before 1947, before penicillin, died of a disease for which, in truth, no fully effective treatment existed. Their deaths are terrible, but they are not different in kind from the deaths of any person who dies of an untreatable disease. They were deceived. But the specific deceiver was their era's medical limitations as much as the researchers' choices. The men who died after 1947 died differently. They died of a disease that medicine could cure. They died because a government agency made a deliberate decision not to cure them, and maintained that decision through the administrations of 7 presidents, across the careers of dozens of researchers, in the face of at least one whistleblower who spent 6 years trying to stop it. Their deaths are not tragedies of medical limitation. They are something else. They are the specific cost of calling something science when it isn't. To tell the story of how the Tuskegee study ran for 40 years, you need to talk about 2 people who are, in some ways, opposite characters, and who together form the most complete picture of how an institution maintains an atrocity for 4 decades. One of them is Eunice Rivers. The other is Peter Buxton. Eunice Rivers was the study's only consistent full-time staff member for its entire 40-year duration. Every director changed. Every researcher rotated in and out. The administrative oversight shifted from the USPHS to the CDC. The funding mechanisms changed. The research questions evolved. The world outside Macon County was transformed almost beyond recognition. 2 world wars, the atom bomb, television, the civil rights movement, the moon landing. Through all of it, Eunice Rivers drove the government car. She drew blood. She handed out aspirin. She called the men by their first names and let them call her Miss Rivers. She was the study. In the way the people who are the consistent human presence in an institution become the institution, she was born in 1,899 inches Early County, Georgia, the eldest of 3 daughters of a sharecropper and sawmill worker. Her mother died when Eunice was 15. Her father, a man who believed, with the particular intensity of someone who has seen what lack of education costs, that his daughters would be educated, worked, extended shifts to finance their schooling, Eunice was sent to mission schools and completed her secondary education at the Tuskegee Institute, where she trained as a nurse and graduated in 1922. She was good at it, not just competent, genuinely talented, in the specific way that a person with high intelligence and extraordinary interpersonal skill becomes talented at work that requires both. She joined the Tuskegee Institute's Movable School, an agricultural extension program that brought education to rural Black communities via a truck that went from farm to farm, delivering not just agricultural knowledge but hygiene training, birthing assistance, childcare information, social hygiene instruction. She was one of 4 Black public health nurses in the entire state of Alabama. She also worked for the Alabama Bureau of Vital Statistics, devising techniques for midwives to accurately report births, a contribution to the state's public health infrastructure that nobody would later remember when her name became associated with the Tuskegee Study. In 1931. Her position at the movable school was defunded in state Depression-era budget cuts. She was working nights at the John A. Andrew Memorial Hospital when the syphilis study was being organized in 1932. Dr. Eugene Dibble, the hospital's medical director and one of the study's Black institutional supporters, recommended her for the position of scientific assistant with the USPHS Division of Venereal Disease. She was offered the job. Let us be clear about what she was being offered. In the specific context of 1,932 inches Alabama, she was being offered steady, professional employment in her field. During the worst economic crisis in American history, in a region where Black women's employment options were stark, nursing positions at underfunded Black institutions, domestic service in white households, or the fields, she was being offered employment with a federal government agency, an unprecedented distinction. As she was among the first Black nurses employed by the United States Public Health Service, she was being offered a salary that was, by any measure, insecure relative to what the alternatives offered. She was being offered professional recognition from an institution whose recognition meant something to a woman who had spent her career navigating a professional world that had been systematically designed to exclude her. She took the job. She did not know, could not have known, in October 1932 that the job she was taking would last 40 years. The study was supposed to run 6 to 8 months. She took a position in a short-term study and found herself in the position of the last person standing when it was still running in 1972. Her role was, by design, central to the study's operational success. The men knew her. They trusted her. In the specific social world of Macon County in the 1930s and 1940s, a world defined by the racial gulf between Black residents and white authority, in which white doctors and government officials were figures approached with caution and a specific and practiced wariness. Eunice Rivers was a bridge. She spoke the language of the community. She knew the families. She attended the same churches, knew the same networks, understood the specific texture of life in Macon County in a way that no white USPHS officer from Washington could approximate. When the government doctors came to town for the annual examinations, they came through Nurse Rivers. When the men had questions, they asked Nurse Rivers. When a man's wife was worried about her husband's health, she called Nurse Rivers. Rivers drove the men to their appointments in the government car. She distributed their aspirin and vitamins. She sat with them during the waiting periods between examinations. She helped families navigate bureaucratic processes. She administered the basic nursing care that the study provided limited, constrained by the study's design to avoid anything that might constitute treatment, but real enough within those constraints to constitute a form of attention that was meaningful to people who had little other access to professional medical care. She was, in other words, the human face of a study whose scientific purpose was to watch those same people die without giving them the drug that would have saved their lives. The question of what Eunice Rivers knew, and when, and what she made of it, is one of the most extensively debated questions in the Tuskegee literature, and it is a question that does not have a clean answer, because Rivers herself gave one extended oral history interview in 1977 to the Harvard Schlesinger Library's Black Women Oral History Project, and in that interview she was careful, deliberate, and notably reticent about the specific ethical questions the study raised. She called the criticism of the study unfair. She defended what she described as the care the men had received. She did not discuss the withholding of penicillin directly. Historians have debated whether Rivers' reticence reflected ignorance, self-deception, professional loyalty, or a more complex and honest understanding of her position that she chose not to articulate publicly. The most careful analyses, those of James H. Jones, Susan Raverby, and others who have spent years with the primary sources, suggest that Rivers understood more than her public statements acknowledged, and that her continued participation in the study reflected a combination of factors that are more difficult to reduce to a clean moral verdict than either her defenders or her critics have typically allowed. She was a black woman in Jim Crow, Alabama, employed by a federal government agency, in a professional capacity that was unprecedented, and that she had no reason to believe would survive if she challenged her employers. The people she was working for were, in the institutional hierarchy of early to mid-20th century American medicine, her superiors in every dimension: race, gender, professional standing, institutional authority. When the white USPHS physicians she worked with made decisions about the study's direction, her options within the social and professional structures that actually existed in Alabama in the 1940s and 1950s were not simply speak up or stay silent. They were considerably more constrained than that. James H. Jones, the historian whose bad blood remains the definitive scholarly history of the Tuskegee study, put it clearly: Rivers' dedication to the study was shaped by race, professional hierarchies, class, and gender in ways that made a simple moral judgment about her choices inadequate. She lived and worked in a society that demanded she defer to white authority as a matter of survival. She had built, over decades, a professional identity and community standing that were intertwined with the study in ways that could not be cleanly separated, and she genuinely believed, or had convinced herself, which in people with her intelligence amounts to the same thing, that she was caring for the men, within the constraints she had been given. The problem with this belief was not that it was entirely false. She was, within those constraints, caring for the men. She was the one person in the study apparatus who knew their names, their families, their histories. She attended their funerals. She helped their children. She was, in the community of Macon County, known as a woman of genuine care. Her students at the nursing school remembered her as the Harriet Tubman of nursing, a woman of extraordinary skill and dignity who knew how to navigate impossible systems while maintaining her own integrity. And she drove them to the appointments where the researchers documented their deterioration and did not treat them. Both of these things are true. The genuine care and the 40 years of service to a study that was killing people she cared for are not contradictory. They are the specific, excruciating texture of moral compromise at the individual level within an institutional atrocity. Rivers was not the architect of the Tuskegee study. She was not the person who decided to withhold penicillin. She was not the person who contacted the draft boards or wrote the letters to local physicians asking them not to treat the men. She was the person who was there every year, for every examination, and who did not stop it. After 1972, when the study was exposed, Rivers went almost entirely silent. She gave the 1977 oral history interview, the one in which she defended her role and called the criticism unfair, and otherwise withdrew from public comment on the subject. She died in 1986. At the age of 86, her headstone, by her family's choice, reads Eunice Verdell Laurie, her married name without the name Rivers that had become attached. Over the 14 years since the study's exposure to one of the most painful chapters in American medical history, the headstone is a choice. It tells you something, perhaps, about how she understood what she had been part of. But it does not resolve the question. Peter Buxton was 29 years old in 1966 when he first tried to stop the Tuskegee study. He was a venereal disease investigator with the USPHS in San Francisco, a young man, educated in history and social science before moving into public health work, with a specific sensitivity to questions of medical ethics that was not, in 1966, and typical of the federal public health bureaucracy. His job involved interviewing people with sexually transmitted diseases, tracing their contacts, and helping to manage the spread of VD in the San Francisco area. He was good at it. He was also, by all accounts, a man who thought carefully about what he was doing and why. In the normal course of his work, Buxton became aware of the Tuskegee study. How exactly he first encountered it is not entirely clear in the historical record. There are slightly different versions of the discovery story, but the relevant fact is that by 1966, he had become sufficiently aware of the study's specifics to have formed a clear view of what it was. He wrote a letter. He wrote to William Brown, the National Director of the USPHS Division of Venereal Diseases, expressing his concerns about the ethics and morality of the extended syphilis study in Tuskegee. He used measured, bureaucratic language, the language appropriate to a junior employee communicating with a senior one. He did not accuse anyone of wrongdoing in the inflammatory sense. He raised questions. He noted the availability of penicillin. He expressed concern about the principle of informed consent. He was careful and professional and clear. The letter was received. It was reviewed. The USPHS convened a committee to consider Buxton's concerns. The committee, composed of researchers and officials with institutional investment in the study's continuation, reviewed the situation and concluded that the study should continue. Buxton's concerns were acknowledged in the bureaucratic sense that a letter of response was sent, and dismissed in the practical sense that nothing changed. Buxton wrote again. He sent additional letters between 1966 and 1969 to various levels of the USPHS hierarchy. He escalated. He argued more forcefully. He raised the specific comparison to the Nazi medical experiments, an analogy that, given the Nuremberg trials had concluded less than 20 years earlier, was not a rhetorical overreach but a precise historical parallel. He pointed out that the men were being denied a treatment that had been standard for 20 years. He pointed out that their wives and children were being infected as a consequence of a study whose scientific value, at this point, could not possibly justify the ongoing harm. The responses he received were, in various formulations, the same response. The study was important. The data was valuable. The researchers were professionals, operating within established protocols. His concerns had been noted. The study would continue. In 1969, the CDC, which had formal oversight of the study by that point, convened the review panel that we discussed at the end of Chapter 1. The panel that included representatives from the CDC, the National Medical Association, and the American Medical Association. Buxton had been raising his concerns for 3 years. The NMA, the organization that represented black physicians, the organization whose members were in the best position to understand the racial dynamics of what was happening in Macon County, joined the CDC and the AMA In recommending that the study continue, let us sit with this for a moment. 3 years after a USPHS investigator had formally raised ethical objections, 22 years after penicillin became standard, in 1969, with the Civil Rights Act 5 years old and the Voting Rights Act 4 years old and the United States having just landed a man on the moon, the organization representing Black doctors in America reviewed the Tuskegee study and endorsed its continuation. The NMA's endorsement was not, by most accounts, a considered or detailed review of the study's ethics. It was an institutional sign-off, offered through local chapter representatives who were asked to weigh in on a matter that the CDC framed as a scientific question rather than an ethical one. But it happened, and its happening was used, subsequently, as evidence that the study had received appropriate professional review and continued to have the endorsement of the relevant medical communities. There was, around the same time, another voice inside the federal public health establishment calling for the study's end. His name was William Carter Jenkins, and he is considerably less well known than either Buxton or Nurse Rivers in the public history of the study, which is itself a piece of historical information worth noting. Jenkins was an African-American statistician in the USPHS and the Department of Health, Education, and Welfare. In 1968, he founded and edited a newsletter called The Drum, dedicated to ending racial discrimination in the HEW. In The Drum, Jenkins wrote explicitly about the Tuskegee study, about its racial character, about the withholding of treatment, about the specific wrong being done to the men of Macon County. He called for it to be ended. He was not heard. The Drum was an internal newsletter with limited distribution. Jenkins did not have the kind of institutional access that would have allowed him to force a formal review. His calls for the study's termination did not succeed, in the documented record, even produce the kind of formal institutional response that Buxton's letters had generated. He called for the end of the study. The study continued. This is worth noting. A black government employee calling for the end of a study that was killing black men was less effective at generating institutional response than a white government employee doing the same. Jenkins's voice more directly situated within the community being harmed, more immediately affected by the racial logic the study embodied, was not heard in the way that Buxton's eventually was. This is a specific fact about how the institutional machinery responded to the moral emergency it had manufactured. It responded to Peter Buxton slowly, inadequately, but eventually in a way it did not respond to William Carter Jenkins. But 1972, Buxton had spent 6 years working within the institutional channels available to him and had failed. He had written letters. He had raised concerns. He had escalated. He had used every mechanism of internal advocacy that the bureaucracy offered. And the bureaucracy had used every mechanism of institutional inertia to absorb his concerns and continue unchanged. He had, in the course of his work for the USPHS, obtained copies of reports and documents relating to the Tuskegee study. He had these documents. He had a decision to make. He made it. He gave the documents to a journalist friend, who passed them to another journalist, Jean Heller of the Associated Press. Heller was a reporter with a track record of serious investigative work. She spent months verifying what Buxton had given her, calling former participants family members, reviewing documents, confirming the facts with medical experts. She was meticulous. She knew she had a story that would require unimpeachable accuracy to withstand the institutional response that would follow. On July 25, 1972, her story appeared on the front page of the Washington Star and moved over the AP wire to papers across the country. For 40 years, the United States Public Health Service has conducted a study in which human beings with syphilis, who were induced to serve as guinea pigs, have gone without medical treatment for the disease, and a few have died of its late effects. Even though an effective therapy was eventually discovered, the response was immediate. Senator Edward Kennedy held hearings. The Secretary of Health, Education, and Welfare announced the formation of an ad hoc advisory panel to review the study. The panel was convened within days. It reviewed the study's records. It concluded, in language that was notably restrained given what it was describing, that the study was ethically unjustified, and that the scientific results it had produced were disproportionately meager compared with known risks to human subjects involved. Ethically unjustified. Disproportionately meager. These are the words that a panel of scientific and medical professionals, reviewing 40 years of watched deaths and withheld cures, produced. They are the words of people trying to find the precise register for a wrong that the vocabulary of scientific review was not entirely designed to capture. The panel recommended stopping the study. In October 1972, the USPHS agreed. In November, the Assistant Secretary for Health and Scientific Affairs formally announced that the study had ended. The study had ended. It had ended because a journalist published a story. It had not ended because a government review found a problem. The 1,969 CDC review had found no problem. It had not ended because a black physician, or a black civic organization, or a black community had forced a reckoning. William Carter Jenkins had tried, and the machinery had absorbed his effort, and continued. It had not ended because of the moral conscience of the medical establishment. 15 years of published papers had not produced a single published objection. It had ended because Peter Buxton, after 6 years of failure, gave a reporter a stack of documents, and a reporter spent months making sure she had the story right. The machinery of institutional science, which had run the study for 40 years, was stopped by a journalist, not by a peer reviewer, not by an IRB. IRBs, institutional review boards designed to provide ethical oversight of research involving human subjects, did not yet exist. They were created specifically in response to Tuskegee, not by the AMA, which had endorsed the study's continuation 3 years earlier, by a reporter on the front page of a newspaper. When the story broke, reactions from within the medical and scientific establishment covered a range from belated horror to extraordinary defensiveness. The most remarkable defensive response came from John Heller, the former study director, the man who had been responsible for the study's management from 1943 to 1948, who had overseen the decision to specifically exclude study participants from penicillin programs being run in Macon County. In interviews with reporters, after the story broke, Heller said, "There was no racial side to this. It just happened to be in a black community. I feel this was a perfectly straightforward study. Perfectly ethical. With controls. There was no racial side to this. It just happened to be in a black community." This sentence delivered not in 1932, before the Civil Rights Movement, before Nuremberg, before the full scale of what racial medicine had produced in both American and German history had become visible, but in 1972, 1 year after the Voting Rights Act had been law for 7 years. In the same year that the Watergate break-in was bringing down a presidency, this sentence is among the most precise distillations of the specific self-deception that makes institutional atrocity possible. It just happened to be in a black community. It did not happen to be in a black community. It was designed to be in a black community. It was designed to be in a black community because being in a black community made it possible. Because the men of Macon County had no political power, no institutional representation, no access to the mechanisms of accountability that might have stopped the study earlier. No lawyers, no senators, no medical societies that were advocating for them. because the structural conditions of Southern poverty and racial inequality had produced exactly the kind of population that the study's designers had identified as an unparalleled opportunity, a population that medicine could study without being required by any effective external constraint. To treat, John Hela diden etusine anihundre aniofias. His obituary in the New York Times documented his many professional accomplishments. It did not mention the Tuskegee study. This, too, is part of the record. On July 26, 1972, the day after Jean Heller's story appeared in newspapers across the United States, the United States Public Health Service issued a statement. The statement acknowledged that the Tuskegee study existed. It acknowledged that it had been running since 1932. It acknowledged that penicillin had been available since the mid-1940s and had not been given to the study participants. It expressed, in the measured language of institutional crisis management, "I regret for any suffering that may have occurred." It did not say that anyone had done anything wrong. It did not say that the study should have been stopped in 1947, when penicillin became standard. It did not say that contacting draft boards to prevent study participants from receiving military medical care had been an ethical violation. It did not say that writing to local physicians and asking them not to treat identifiable patients with a treatable disease had been an ethical violation. It did not say that publishing 15 papers over 36 years describing an ongoing study of untreated syphilis in human subjects in peer-reviewed journals accessible to the entire American medical establishment, without generating a single published ethical objection from that establishment, was a failure of the profession. It said the study existed, that penicillin had been available, and that there was regret for any suffering. The USPHS issued this statement while simultaneously defending the study's scientific value and maintaining that its procedures had been appropriate for their era. Senator Edward Kennedy did not find this adequate. Kennedy, who was chairman of the Senate Health Subcommittee, announced hearings within days of the story breaking. The hearings, held in February and March of 1973, were the first formal public accounting of what the study had been and what it had done. Witnesses included former study participants, researchers, public health officials, and experts in medical ethics. The hearings were, by the standards of congressional proceedings, substantive. Kennedy and his colleagues asked specific questions, demanded specific answers, and made clear that the political establishment was not going to absorb the Tuskegee story as quietly as the medical establishment had absorbed 15 years of peer-reviewed papers. The ad hoc advisory panel, convened by the USPHS, had already, in October 1972, concluded that the study was ethically unjustified. The panel's formal report, released in 1973, went further in its detailed findings. It found that the men had never been told the true purpose of the study. It found that they had not given informed consent to participation. It found that effective treatment had been deliberately withheld. It found that the study's scientific value, measured against the harm it had caused, was insufficient to justify its continuation at any point after penicillin became available. They recommended that the surviving participants receive comprehensive medical care and that the relevant government agencies develop new frameworks for the ethical oversight of research involving human subjects. What it did not do, and what the Kennedy hearings did not do, and what no subsequent government proceeding ever did, was name individuals as responsible and hold them accountable in any legal or professional sense. No researcher was prosecuted. No researcher lost their medical license. No researcher faced professional sanction from the American Medical Association or any other credentialing body. The people who had written the letters to draft boards, who had written the letters to local physicians, who had made the decision to exclude study participants from penicillin programs being run in their own county, who had published 15 papers about watching men die of a curable disease. These people were not called to account in any way that their professional standing registered. John Heller, the former study director who had told reporters the study was perfectly ethical, with controls, died in 1989 with his professional reputation intact. His New York Times obituary listed his many contributions to public health without mentioning Tuskegee. The other researchers who had run the study continued their careers. Some retired with honors. One of the later directors of the study received a Distinguished Service Award from the CDC. This is the specific character of institutional accountability in cases where the institution itself is the wrongdoer. The institution apologizes, creates commissions, proposes reforms, and protects the individuals who operated within it. The system failed. The people were just doing their jobs. The jobs happened to involve watching men go blind, go mad, and die of a disease a prescription could have cured. But the jobs were legitimate jobs, assigned by legitimate institutions, performed within the framework of legitimate scientific practice. The institutional accountability that did happen was financial. In July 1973, Attorney Fred Gray, a black civil rights lawyer from Alabama, who had represented Rosa Parks, Martin Luther King Jr., and numerous other clients whose cases had defined the legal landscape of the civil rights era, filed a class action lawsuit on behalf of the Tuskegee study participants and their families against the federal government. The lawsuit named as defendants the United States of America, the Department of Health, Education, and Welfare, the USPHS, the CDC, the state of Alabama, and several individual officials who had been involved in the study's administration. The suit sought $1.8 billion in damages. In December 1974, the government settled out of court for $10 million, $10 million, divided among the surviving participants, their wives, their widows, and the heirs of those who had died. The settlement was structured in 4 categories. Living participants with syphilis received $37, $500 each. Living participants in the control group, the 201 men who had been enrolled without syphilis, received $16, $000 each. The heirs of deceased syphilitic participants received $15, $0 per estate. The heirs of deceased control group participants received $5, $0 per estate, $37,500. For a man who had spent 40 years being watched by government doctors while they withheld the drug that would have cured him, who had told his wife she might have syphilis because the government doctors hadn't mentioned that was something to worry about, who had lived through the decade in which his aortic wall was being weakened by a disease that a $20 prescription would have stopped. $37,500 after taxes from a government that had spent 40 years treating his body as a data source. The settlement came without an admission of wrongdoing. This is standard in out-of-court settlements. It is also, in this specific context, a precise legal encoding of the institutional logic that had made the study possible in the first place. The government paid. It did not admit it had done anything wrong. It had done something that cost it $10 million to settle, the terms of which included ongoing medical care and burial coverage for survivors and their families through what became the Tuskegee Health Benefit Program, but it had not, in any legal or formal sense, done anything wrong. The 399 men had not been wronged by anyone specifically. They had been wronged by a study. The study had been conducted by an agency. The agency had employed researchers. The researchers had made decisions, but the decisions were institutional decisions, made within an institutional framework, endorsed by institutional reviews, published in institutional journals. There was no one to charge. The Tuskegee Health Benefit Program. established in March 1973 before the settlement was finalized, provided surviving participants with medical care, burial assistance, and related benefits. In 1975, participants' wives, widows, and children were added to the program. In 1995, descendants were added. The program continued operating for decades, a specific, ongoing commitment by the federal government to care for the people it had spent 40 years not caring for, funded through the same USPHS infrastructure that had run the study in the first place. By the time the study was closed, the death toll was as follows. 28 men had died directly of syphilis. More than 100 had died of related complications, the cardiovascular disease, the neurological deterioration, the accumulated damage of decades of untreated late-stage infection. At least 40 wives had been diagnosed with syphilis, infected by husbands who had been told for years they were receiving treatment for the disease that was infecting the women who loved them. 19 children had been born with congenital syphilis, a disease that causes bone deformities, seizures, neurological damage, blindness, and death in infants, transmitted from infected mothers during pregnancy. 40 wives, 19 children, people who were never part of the study, people who never signed anything, agreed to anything, received anything in exchange for their participation. People who were harmed as a direct consequence of a study that had kept their husbands and fathers sick when a cure existed, and had done so in the name of science. The 19 children born with congenital syphilis are, in the accounting of the Tuskegee Study's human cost, among the figures that most directly illuminate the study's specific moral character. They were not harmed by the disease in the abstract. They were harmed because the study's design required that the men remain infected, which meant the men could continue to infect their wives, which meant that pregnant women with syphilis gave birth to children with congenital syphilis. The harm to the children was not an unforeseen consequence of the study. It was a predictable consequence. It was, in any honest assessment of the study's downstream effects, anticipated by anyone who understood the disease's transmission pathways and chose to maintain untreated infection in a population that included sexually active men with wives and partners. The researchers understood the disease's transmission pathways. They had published papers about them. In the aftermath of Tuskegee, the United States government did something that it does rarely and inadequately. It substantially reformed the regulatory framework governing medical research on human subjects. The National Research Act, signed into law by President Nixon in July 1974, created the National Commission for the Protection of Human Subjects of Biomedical and Behavioral Research, a body charged with identifying the basic ethical principles that should govern the conduct of research involving human participants, and developing guidelines to ensure that research was conducted in accordance with those principles. The commission worked for 4 years. In 1979, it published its conclusions in a document that has since become foundational to the ethics of medical research everywhere in the world. The Belmont Report. The Belmont Report established 3 core principles for the ethical conduct of research involving human subjects. Respect for persons, which required that individuals be treated as autonomous agents, and that those with diminished autonomy be protected. The beneficence, which required that researchers maximize possible benefits and minimize possible harms. And justice, which required that the benefits and burdens of research be distributed fairly, and that vulnerable populations not bear the costs of research whose benefits would accrue to others. The Belmont Report also established the requirement that all research involving human subjects be reviewed and approved by an independent institutional review board, an IRB, before it began, and that this review includes specific attention to the adequacy of informed consent procedures. The risk risk-benefit ratio of the research, and the equitable selection of research subjects, institutional review boards, informed consent requirements, risk-benefit analysis as a prerequisite for research approval. These are now the baseline infrastructure of medical research everywhere in the developed world. They are so fundamental to how clinical research works that it is difficult for anyone trained in medicine or public health in the decades since 1979 to imagine research proceeding without them. They did not exist before Tuskegee. This is the specific regulatory legacy of 40 years of watch deaths, a set of institutional requirements designed to prevent the next Tuskegee by making the first Tuskegee structurally impossible to replicate. No IRB, reviewing a study in 1932, would have approved the Tuskegee design even by 1932 standards, if genuinely independent. No IRB, reviewing the study in 1947, would have approved its continuation after penicillin became available. No IRB would have approved the draft board interventions, the letters to local physicians, the exclusion from treatment programs. The existence of an IRB would not guarantee ethical research institutions can and do corrupt their own oversight mechanisms, as the history of science demonstrates repeatedly. But it creates a formal barrier, a specific procedural requirement, that makes some of the worst abuses of research ethics harder to sustain for 4 decades without external challenge. The IRB system is Tuskegee's gift to medical research ethics, if gift is a word that can be applied to a reform extracted from 40 years of human suffering. It is what the study cost the medical establishment in terms of regulatory constraint. It does not come close to equaling what the study cost the men of Macon County in terms of human life. The Nuremberg Code, written in 1947 inches response to the Nazi medical experiments, had already established the principle of voluntary informed consent as an absolute prerequisite for any medical research on human beings. The Nuremberg Code had been in existence for 25 years when the Tuskegee study was still running. The Tuskegee study was conducted by American government physicians, by the successors and counterparts of the American prosecutors who had written the Nuremberg Code in explicit, documented violation of its principles. For 25 years after those principles were established, the Belmont Report was necessary, because the Nuremberg Code, without domestic legal enforcement mechanisms, had not been sufficient to stop it. The formal government apology for the Tuskegee study came on May 16, 1997, 25 years after Jean Heller's story, 23 years after the settlement, 8 years after John Heller's untroubled obituary in the New York Times. 5 of the original study participants were still alive. They were older men in their 80s and 90s. Some of them, and they had been invited to the White House to hear the President of the United States tell them that what had been done to them was wrong. President Bill Clinton stood at the podium in the East Room and said the things that should have been said decades earlier. What was done cannot be undone. But we can end the silence. We can stop turning our heads away. We can look at you in the eye and finally say on behalf of the American people, what the United States government did was shameful. And I am sorry. He said the study was deeply, profoundly, morally wrong. He said it had revealed the depths to which misguided science can sink when it is guided by arrogance and racism. He announced funding for the establishment of what would become the National Center for Bioethics in Research and Healthcare at Tuskegee University, an institution whose existence is, in itself, a specific kind of accounting. The government that ran the study funding, a center at the university that provided the study's institutional home, dedicated to preventing the repetition of what it had done. Then one of the survivors spoke. Herman Shaw was 94 years old. He had been enrolled in the Tuskegee study in 1932. When he was 29, he had come to Washington, 65 years later, to hear the president apologize. He spoke briefly, with the specific dignity of a man who has decided, after decades, what he wants to say, and will say it, without excess. He said, "It is my hope that by our presence here today, we are able to put to rest the nightmares of the past and allow the healing to begin." Herman Shaw, 29 years old, in 1932. When the government doctors came to Macon County and told him he was being treated for bad blood. 94 years old in 1997. Sitting in the White House, watching a president say the words that no president had said in the 65 years since the study began. Having spent those 65 years his entire adult life, from his late 20s to his late 90s, carrying the specific knowledge of what had been done to him, and what it had meant, and what it had cost. He wanted the healing to begin. He did not say he forgave anyone. He said he wanted the healing to begin. Clinton's apology was real. It was late, but it was real. And it was specific. It said what was wrong and who had done it and to whom. It was accompanied by a concrete commitment. The Tuskegee University Center. And by the ongoing operation of the Tuskegee Health Benefit Program. It was, as presidential apologies for historical wrongs go, more substantive than many. It could not undo 40 years. The last survivor of the Tuskegee study, the last of the original 399 men to die, passed away in January 2004. He was 107 years old. He had been enrolled in the study at the age of 35. In 1932. He had outlived the study by 32 years. He had outlived the settlement, the Belmont Report, the congressional hearings, the presidential apology. He had lived long enough to see the federal government acknowledge, in the East Room of the White House, that what had been done to him was shameful. He died anyway. Not of syphilis. He had received treatment after the study ended. He died at 107. Which is simply a very old age. But he had lived those decades with the specific knowledge of what had been done to him in the years when the government doctors had told him he was being cared for. And now we need to talk about Guatemala. Because the Tuskegee study, as terrible as it was, I was not the only thing the United States Public Health Service was doing in the 1940s in the name of syphilis research. In 2010, 63 years after the experiments were conducted, 38 years after the Tuskegee study was exposed, the United States government apologized for another syphilis experiment. This one had not involved watching men who already had syphilis without treating them. This one had involved deliberately infecting healthy people with syphilis. Between 1,946 and 1,948. Researchers with the United States Public Health Service, some of the same researchers involved in the Tuskegee study, operating with the support of the same institutional apparatus, conducted a series of experiments in Guatemala in which they deliberately infected hundreds of Guatemalan citizens with syphilis, gonorrhea, and chancroid. The subjects included soldiers, prisoners, psychiatric patients, and orphaned children. They were not told what was being done to them. They did not consent. Many were infected through the deliberate introduction of bacterial cultures into abraded skin or mucous membranes. Some were infected through arranged sexual contact with infected sex workers. Some were then treated with penicillin. Some were not. The purpose of the Guatemala experiments was to test whether penicillin could prevent syphilis infection if administered prophylactically before exposure rather than after. This was a genuine scientific question. The answer to it was obtained by infecting human beings, without their knowledge or consent, with a disease that could damage their hearts and brains, and could kill them. In a country whose population had even less access to institutional protection than the men of Macon County, the Guatemala experiments were discovered not through a whistleblower or a journalist, but through a historian. Professor Susan Reverby, the same scholar whose work on the Tuskegee study had made her one of the world's foremost authorities on its history, was conducting archival research in 2005 when she found, in the papers of John Cutler, a former USPHS physician who had been involved in both the Guatemala experiments and the later management of the Tuskegee study. Documentation of what had been done in Guatemala. She spent 5 years verifying her findings before going public. In 2010, President Obama called the Guatemalan president to apologize personally. Secretary of State Hillary Clinton and Health and Human Services Secretary Kathleen Sebelius jointly issued a public statement describing the Guatemala experiments as clearly unethical and saying they were outraged that such reprehensible research could have occurred under the guise of public health. Under the guise of public health. The same phrase, the same logic, the same institutional infrastructure. Tuskegee was the study that everyone knows about because Jean Heller wrote a newspaper story in 1972. Guatemala was the study that almost nobody knew about for 60 years because the documents were in a box in a dead man's papers and a historian happened to find them. The Guatemala experiments used penicillin, the drug that the Tuskegee study participants were not given as part of their design. The researchers in Guatemala had penicillin. They had it because it was 1946, the standard treatment for syphilis. They used it to treat some of the people they had deliberately infected. They did not use it to treat some of the people they had deliberately infected. In order to document the disease's natural progression, back in Alabama, simultaneously. The Tuskegee study was documenting the disease's natural progression in men. It was specifically preventing from receiving the same drug. The same researchers, the same years, the same drug used in Guatemala to treat some of the people they'd infected, withheld in Alabama from men who'd already had the disease for years. The USPHS was running both programs simultaneously, with the endorsement of its senior leadership, John Cutler, the physician who ran the Guatemala experiments, whose papers, Reva B. found in 2005 later, became one of the primary defenders of the Tuskegee study when its ethics were challenged in the 1960s and 1970s. Cutler was among those who argued for its continuation. He participated in the 1969 CDC review that reaffirmed the study should proceed. He died in 2003, 1 year before the last Tuskegee survivor, without ever publicly acknowledging wrongdoing in either Guatemala or Tuskegee. The Guatemala experiments were not prosecuted. No one was charged. An advisory committee issued a report in 2011 concluding that the experiments violated ethical norms and constituted wrongful acts. The report did not name individuals as criminally responsible. The Guatemalan victims and their families received no compensation from the United States government. A lawsuit filed on their behalf in U.S. federal court was dismissed in 2012 on the grounds that the U.S. government could not be sued for actions taken on foreign soil. The people in Guatemala were infected deliberately with diseases the researchers had introduced. They were not compensated. Their government was told sorry. The advisory committee published a report. The researchers who had done it were long dead. The institutions that had funded and authorized it expressed regret. This is the full arc of what institutional accountability looks like when the institution is the United States government and the people who were harmed were poor, black, or Guatemalan. Now let us talk about what the Tuskegee study costs today. Not in 1972. Not in 1997. Today, the 2016 study by economists Marcela Alsan and Marianne Wanamaker, published in the Quarterly Journal of Economics. One of the field's most rigorous peer-reviewed journals, is the most methodologically careful examination of the Tuskegee study's long-term effects on black health in the United States. What Alsan and Wanamaker found was not anecdote or impression. It was a measurable, statistically significant, specifically documented set of behavioral and mortality changes in the black male population that correlated in timing and geography with the disclosure of the Tuskegee study in 1972. Their method was elegant and careful. They used the geographic variation in the intensity of the Tuskegee study's coverage, comparing counties closer to Tuskegee, where the story hit harder and with greater local specificity, to counties farther away, and examined what happened to health-seeking behavior and mortality among Black men over 45 in those counties. After 1972, their findings were striking. After the Tuskegee disclosure, Black men over 45 in counties with greater exposure to the story showed measurable reductions in both outpatient physician visits and hospital admissions, evidence that men in those areas became less likely to seek medical care. The effect was specific to Black men, not Black women or white men, which is consistent with the hypothesis that it was driven by the Tuskegee story's specific relevance to the population most directly represented in the study. And the reduction in health-seeking behavior correlated with a measurable increase in mortality. Alsan and Wanamaker estimated that the Tuskegee disclosure explained approximately 4 years of reduced life expectancy for Black men over 45 in the most affected areas. Israelka, 4 years of reduced life expectancy across the affected population as a consequence of the reduction in health-seeking behavior caused by the legitimate, historically grounded distrust that the study's exposure had created. This is a conservative estimate. It measures only the effects attributable to the 1,972 disclosure in the specific time window the researchers studied. It does not attempt to measure the effects of the knowledge of Tuskegee as it spread through the Black community over subsequent decades, through oral transmission, through grandparents telling grandchildren, through community conversations, through the specific kind of institutional memory that communities maintain about the things that have been done to them. It does not measure the effects on younger generations who grew up hearing about Tuskegee before they encountered the medical system for the first time. The full cost of Tuskegee in terms of lives lost to medical avoidance is, by any plausible estimate, larger than 128. It is larger than the number Alsan and Wanamaker calculated. It is a number that medicine has not been able to compute precisely because it involves a counterfactual, the lives that would have been lived if the study had never happened. If the trust had never been broken, that cannot be measured directly. We know it is large. We know it is ongoing. And we know exactly where it came from. In 2021, as COVID-19 vaccines were being distributed across the United States, and public health officials were struggling to reach hesitant communities, surveys consistently found that Black Americans expressed lower initial confidence in the vaccines than white Americans. The reasons cited were multiple and legitimate structural distrust of institutions that had historically failed Black communities, specific concerns about the speed of vaccine development, general skepticism about a government health initiative being promoted aggressively by the same government that had, within living memory, failed in numerous ways to protect Black health. But the reasons cited most specifically, in focus group after focus group, in community conversation after community conversation, was Tuskegee, not as a vague cultural memory, as a specific event that a significant portion of the Black American population knew about and referenced explicitly when asked why they were hesitant about a government-endorsed medical intervention. COVID-19 killed more than 1 million Americans between 2020 and 2023. Black Americans died at disproportionately high rates throughout the pandemic, driven by a combination of factors including occupational exposure, housing density, underlying health conditions shaped by decades of structural inequality in healthcare access, and lower rates of vaccination. The degree to which vaccine hesitancy driven by Tuskegee-related distrust contributed to this excess mortality is difficult to isolate statistically, but the hesitancy was real. The connection to Tuskegee was documented, and the people who expressed it were not being irrational. They were applying a historically accurate assessment of what the government had done when it had, in the past, told black communities that it was offering medical help. The government had watched their grandfathers die of syphilis and called it science. Is it entirely surprising that some of their grandchildren had questions about the vaccine? This is the specific arithmetic of institutional betrayal. The costs compound over time. The men who died of untreated syphilis between 1,947 and 1,972 are the proximate dead, the ones whose names appear in government records and whose deaths can be attributed directly to the study's design. The men and women who died of preventable diseases in the 1970s and 1980s and 1990s because they avoided the doctor, after learning what the government had done, are the secondary dead not counted. Not named. I not compensated. Not apologized to. The people who died of COVID-19 in 2021 who might have survived, had the Tuskegee Study's shadow not extended 40 years into their community's relationship with medicine, are the tertiary dead even harder to count, even less likely to appear in any official accounting. They count anyway. There is a specific question that the Tuskegee Study raises for the history of science, a question that connects it to every other episode in this series, and it is worth asking directly. How does a peer-reviewed scientific study run for 40 years? The answer is not that the peer reviewers were all evil. It is not that medicine in the mid-20th century was uniformly racist, or that everyone involved in the study was incapable of moral perception. The study included black professionals Eunice Rivers, Dr. Eugene Dibble, the NMA representatives who endorsed the 1,969 review whose own communities were being harmed by it, and who continued to participate in it or declined to challenge it for reasons that were complex and that reflected the specific constraints of their social and professional positions. The answer is that peer review, as it was practiced in mid-20th century American medicine, was a mechanism for validating scientific methodology for assessing whether the data had been collected properly, analyzed correctly, and reported accurately. It was not a mechanism for assessing whether the underlying research design was ethical, or whether the population being studied had been treated as ends in themselves rather than as means to a scientific conclusion. A paper describing the cardiovascular effects of untreated syphilis in a study population was reviewable for its statistical methods, its diagnostic criteria, its comparison to control groups. It was not reviewable by any formal mechanism that existed for whether the study population had consented to being studied or was receiving care appropriate to their medical condition. The peer review system that existed in 1936 and in 1947 and in 1955 and in 1964 was designed to answer the question, is this good science? It was not designed to answer the question, is this science that should be done? Those are different questions. For 40 years, the Tuskegee study was peer-reviewed for the first question and not asked the second. This is the specific failure that the Belmont Report and the IRB system were designed to address, creating an institutional mechanism that asked the second question before the science started, and that had enough independence from the researchers to give the question a meaningful answer. But the lesson of Tuskegee is not simply that we need better review mechanisms. The review mechanisms exist now, and they are imperfect, and they can be gamed, and they have been. The lesson of Tuskegee is about the specific conditions under which science loses its ability to see the humanity of the people it studies. Those conditions are not mysterious. They are well documented. They involve power, specifically the concentration of scientific authority in institutions whose leadership does not include and is not accountable to the communities whose bodies are being used as data sources. They involve poverty, the specific way in which economic desperation makes people accessible to research designs that treat their participation as a bargain rather than a right. They involve race, the specific history of American medicine's treatment of black bodies as available for study for experiment, for use, in ways that white bodies were not a history that stretches back, as historian Harriet Washington and others have documented, through the antebellum period's use of enslaved people for surgical experiments, through the grave robbing of black cemeteries to provide cadavers for medical schools, to Tuskegee and beyond. And they involve the specific cognitive architecture of institutional science, the way in which the production of peer-reviewed knowledge can generate its own justification, so that the question, should we continue the study, is answered not by reference to the interests of the people being studied, but by reference to the interests of the data set. The data is valuable. The data is accumulating. The data requires subjects. The subjects are available. The study continues. The study continues because stopping it requires someone to explain why it should stop. And explaining why it should stop means admitting why it should never have started. And admitting that means accounting for every decision made in the years between the start and the stop, the draft board letters, the letters to local physicians, the 1,947 decision not to prescribe penicillin, the 1,950 decision to exclude participants from local treatment programs, the 1,969 review that endorsed continuation. Each of those decisions is defensible within the logic of the study. Each of those decisions is indefensible outside it. Stopping the study means stepping outside the logic of the study. And institutions are extraordinarily resistant to stepping outside the logic of themselves. This is why it took 40 years. And not because everyone involved was a monster. Because institutions protect their logic the way organisms protect their biology automatically. Persistently. Without necessarily meaning to, until the external pressure becomes too great. The external pressure, in the case of Tuskegee, was a journalist with a stack of documents and 6 months to make sure she had the story right. The story was right. On July 25, 1972, Jean Heller published it. 40 years ended. 128 directly countable deaths stopped being accumulated. The wives and children of those who died were not compensated in proportion to what had been taken from them. The researchers were not prosecuted. The institution apologized 25 years later. The last survivor died in 2004, at 107. The distrust the study created is alive today. It is alive in the communities that carry the knowledge of what was done. It is alive in the medical offices where a black patient looks at a white doctor and wonders, with entirely reasonable historical justification, whether the care being offered is the care it claims to be. It is alive in the surveys that ask why vaccine uptake differs across communities and find, repeatedly, that Tuskegee is among the answers. It is alive in the excess mortality statistics, the ones Alsan and Wanamaker measured, and the ones that nobody has measured yet, because the researchers with the tools to measure them are not, for the most part, studying the ongoing cost of institutional betrayal on health outcomes across generations. The study called itself science. 15 papers in peer-reviewed journals, from 1936 to 1973, said it was science. The American Medical Association, reading those papers, did not disagree. The National Medical Association asked in 1969 whether the study should continue, did not disagree. The CDC, reviewing the study's ethics through 6 administrations, did not disagree. The men of Macon County, who had been told they were being treated for bad blood while their aortas were being weakened by a bacterium, the government was choosing not to eliminate. I never got to disagree. They were not told enough to disagree. They were told they were being helped. They were not helped. That is what peer review approved. That is what 15 papers documented. That is what the institutions built to find truth. the USPHS, the CDC, the AMA, the NMA, the universities that gave the researchers their credentials and the journals that published their findings endorsed, permitted, sustained, and defended until a journalist with a stack of documents made it impossible to defend any further. The institution did not manufacture a lie, in the obvious sense the way tobacco companies manufactured scientific doubt, or the way Andrew Wakefield manufactured data. It manufactured something more durable, more respectable, and in some ways more dangerous, a scientific framework within which watching human beings die of a curable disease was not a lie, but a study, not a crime, but a protocol, not a betrayal, but a 40-year observation period. The observation period ended. The 399 men remain.